Good morning, friends. Myself, Dr. Srinidhi Kumar Acharya. Please subscribe my channel, Medical Classes by Srinidhi Kumar Acharya, and also don't forget to give the comments. Thank you very much. So, in the last class, we have seen some of the clinical interrogations related to Shayya mutra or nocturnal enuresis. This is the continued part of the same. Now we have to do some of the physical examination. So what are the different points that have to be seen in physical examination when we are dealing with a patient of nocturnal enuresis or Shayya mutra? Visualization of the urinary system and examination of the abdomen. Then we have to be more focused on urinary system and also examination of the abdomen. Then we have to also look into renal and bladder masses, and we have to also look into the genital for hypospadiasis, epispadiasis like conditions, because these are also the most common causes. Okay, congenital abnormalities, because we know that congenital abnormalities related to the genital system or the urinary system are always the most common causes of primary type of nocturnal enuresis. There may be some neurological abnormalities also, therefore examination of the neurological system is also important, especially peripheral reflexes, perianal sensations, then tone of the muscles, then gait of the child. So these things are very important. In the lower back, we have to see the tuft of the hair and some other vertebral anomalies, because we know that meningocele, meningomyelocele, etc. These conditions are commonly associated with the incontinence of the urine, so that has to be seen. Then we have to look into the tonsils, adenoids, because obstructive sleep apnea is one of the most common cause of nocturnal enuresis. Now identify the anus and as well as vaginal opening and urethral opening, examine it properly, and if it is not seen, then there is a chance of labial adhesion, which is most commonly associated with the ectopic ureter. Then check the underwear or undergarments to assess the wetness, stool streaking and stool around the anus, and perianal tears and as well as fissures. So these type of presentations are common in case of ectopic bladder, constipation and encopresis like conditions. Then we have to look into the sacral dimples, tuft of the hair over the midline, abnormal or asymmetric gluteal cleft, tethered cord and cord lipomas, and persistent ductal sinuses, etc. And these are all some of the structural problems which may lead to nocturnal enuresis or Shayya mutra. Now UTI, we know that the children with the UTI are associated with the fever usually, and tenderness probably in the urinary tract area while passing the urine, or there may be burning sensation, and also there's tenderness over the kidney area or the bladder area or the inflammatory discharges in the genital area. So we are going in very detail about the physical examination. Whenever it is required, you have to do it, otherwise there is no need. Constipation is suggested by the presence of the hard stool in the left lower quadrant and the hard impacted stool by the rectal examination. So you also go for rectal examination if you want to confirm about the constipation. Now examination of the neurogenic bladder should be assessed by the motor tone, power, sensation and as well as spinal and plantar reflexes in the lower extremities. Anal area should be checked for intact anal wing. Anal wing means stretching of the anal skin. Okay, so anal wing, sometimes that may be also one of the cause. So urethra, as we discussed earlier, urethral obstruction is also associated with the enlargement of the bladder and kidneys. And meatal stenosis, you have to look into meatal stenosis also, whether the stenosis of the urethral openings and all. This is recognized by inspection of the caliber of the urethral meatus and urinary stream. By looking at the urinary stream also you can say whether it is stenosed or obstructed. Now look at the family history of the enuresis, because family history plays a very important role in nocturnal enuresis. Okay, a dietary history about the time, quantity and type of the fluid and solid intake by the patient, assessment of the emotional impact, any history of teasing by the family members or friends, or history of UTI, we are telling many times, history of constipation, neurogenic bladder, spinal cord tumors, urethral obstruction, all these things we have already discussed, so I will not go in detail. Yes, now we come to the treatment part, which is very important. So when you are going for the treatment, therapeutic responses, we have got some of the terminologies and we have to understand these terminologies. Okay. So one is called as initial success, lack of success, continued success, complete success, and relapse. Anything can happen when you are treating a patient of Shayya mutra. What do you mean by initial success? Initial success means there are 14 consecutively dry nights after starting your treatment, whatever reinforcement treatment that you have started, positive reinforcement treatment. For 14 days, child is continuously for the 14 days, child is improving very rapidly, and dry nights, child is not passing urine. And this is called as initial success. Okay. Lack of success means failure to meet the above criteria. After giving the medications also, child is not improving and there is no dry nights. The same is continued. Then it is called as a lack of success. Continued success. What do you mean by continued success? There is no relapse after 6 months of initial success. Initial success up to 14 to 15 days, there is no problem. Everything is fine. And the same situation, response was if it is continued for next 6 months, then we will call it as continued success. Complete success means there has no relapse since last 2 years. You have started treatment, you have started giving Ayurvedic treatment, and there is no relapse after 2 years also. So then it is called as continued or complete success. Not continued, complete success. Relapse. What do you mean by relapse? This is very important. When 2 or more wet nights within 2 weeks of initial success, and then the interval between the initial success and interval between the relapse is measured. There can be relapse. That means 2 or more wet nights within 2 weeks of initial success. That means for first 14 to 15 days there is no problem. And later onwards there is 1 or 2 times baby passed the urine within 2 weeks. Not daily, within 2 weeks. He again passed. So then this is called as a relapse. So these are some of the terms that we have to know when we are dealing with the treatment. Yes. Now what are the investigations required? Some of the non-invasive investigations are required. Number 1 is urine analysis. So don't forget to go for simple urine analysis. Is the most important test of the patient with the daytime wetting. Okay, baby is also having daytime wetting. Then don't forget to go for, don't miss the urine analysis. That has mandatory because we have to rule out infection, we have to rule out diabetes mellitus, we have to rule out diabetes insipidus. So a complete urine analysis must. Okay, so urine and culture for sensitivity should be also done. Okay, urethral obstruction is associated with the RBC in the urine. Usually urethral obstruction will have hematuria also. So we have RBC in the urine. If the urine specific gravity is greater than 1.020, it rules out diabetes insipidus. Presence of the glucose in the urine, again it confirms diabetes mellitus. Now there is another investigation, that is uroflowmetry. Uroflowmetry, very simple investigation and non-invasive one. Urine flow is helpful to identify the neurogenic bladder and urethral obstruction. So uroflowmetry will do that. Okay. So failure to empty the bladder in a given time, so that is responsible, that may be because of UTI-like conditions. Next, you can also go for ultrasound to find out any residual volume of the urine which is remaining there. Normal residual urine is less than 10 ml, and if it is more than 10 ml, then it may suggest the residual urine, and there's a collection of the urine in the bladder. It is not completely evacuated, and that may be also one of the causes of this. So this can be done by simple ultrasound. Patients with the neurogenic bladder and urethral obstruction usually have thick and trabeculated bladder. This you get it from USG. USG also shows that thick and trabeculated bladder, and this is seen usually in neurogenic bladder as well as urethral obstructions. And this is evidence of a hydronephrosis and cortical scarring. In the USG, we'll have hydronephrosis and cortical scarring. USG of the kidney and bladder, if it is normal in patients with only daytime enuresis. So that means I am not going in detail. These are some of the investigation that you can do according to need. I am not telling that in all the patients you have to go for this investigation, but my suggestion is simply go for one urine analysis and look at the urine analysis findings, and then accordingly you decide which further investigation we have to do. Other investigation is voiding cystourethrogram can be done. This is especially for neurogenic bladder. Lumbosacral spine should be visualized to look for the sacral agenesis and some of the lumbosacral flexus problem and spinal problems. And video urodynamic study. These are the further investigations, later investigations. If there is a need, you can go for that. Now, urine analysis is mostly mandatory in all the cases. No other investigations are indicated. In the urine, there may be leukocyte esterase, there may be nitrates, there may be WBC, RBC, protein, glucose. These things we have already discussed, and this helps to differentiate between the UTI, proteinuria, hematuria, diabetes mellitus, etc. We have already seen that. Yes, now we come to the management part. To minimize the embarrassment and anxiety of the child and also of the parents, now you have to start the treatment. Why we have to start the treatment? Because it minimizes the embarrassment, anxiety of the child and also anxiety of the parents. Many of the time what happens is, if simply advise them some of the guidelines and send them back, so they are not satisfied. So you have to start with some therapeutics. Okay, that greatly helps us to reduce their anxiety. Child with enuresis will benefit from getting care from the parents and also approached by the doctors. Now, that's what I previously also have explained. A child with enuresis will benefit from getting care from the parents and approached by their doctors. Doctors also suggest some of the points, and parents also guide, because parents will be there with the child throughout the day and night, so they should be also properly educated. Children should be instructed to never overeat or drink excess with the dinner. That means excess fluid intake, especially after evening hours, should be reduced, and also suggest that don't overeat. Okay, so children are advised to take recommended hours of sleep as per age. This is also important. Don't sleep too much. Sleep hygiene, maintenance of sleep hygiene is also very important. Okay, so at the age of 5 to 6 years, usually kids need 11 hours of sleep. At 7 years, they need about 10.5 hours sleep. 8, 9, 10 years, they need 10 hours of sleep. At 11 years, they need 9.5 hours of sleep. And 12, 13, 14 and 15 years, they require about 9 hours of sleep. And later onwards, in average, they require about 8 hours of sleep. Anything more than this is restricted. Okay, this much of minimum sleep they should have. Psychotherapy and training, that should be also tried. The reassurance to the parents should be given. Parents should be reassured. Encourage the child for dry nights. That means you have to do different encouraging methods. It may be gift, offering the gift, or it may be some. This is called positive. Encourage the child for dry nights. A reward should be given. Dry nights should be plotted on a calendar, and fluid restriction should be done. Then LRA method should be followed, and spending the time with the child is very important. No punishment should be given, only encouragement should be given. Humiliation should not be done, or child abusement should not be done. And that means ridicule by siblings and friends should be avoided. Bullying, etc. should be avoided. So these are some of the basic information regarding points in the psychotherapy and training, because this is a platform upon which we are treating the child. First, we have to correct this platform. We have to create a platform, and then we have to go for the treatment. Now, what are the general management methods? So, avoid excessive fluids. Yes, we know that. Empty the bladder at bedtime. Then hold to wake up at night and empty the bladder. That means, so night time he has got a problem when the bladder is full, so suddenly he passes the urine. So in the daytime, you educate him to hold the urine for some time. Suppose when he is now eager to void the urine, ask him to hold it for 10 minutes. If you do in excess, it will be Vegadharana. It's not like that. Ask him to hold him for 10 minutes. So this helps at night hours. So at night, so by this night hours, he will not pass spontaneously at once. Okay, this training. So this training can be done. Urine withholding training. Okay, improve the access to the toilet, and toilet should be nearby. It should not be too far away. Okay, improve the child. That is cleaning up. Whenever suppose the child passes the urine and bedsheet, now without punishing him, without scolding him, simply involve the child also in cleaning these bed sheets. Don't tell that you have done a big mistake, therefore we are doing this. You simply call him and also include him in this process of cleaning the bed sheet and beds and all those things. Then one day child definitely ask, why we are doing all these things, mama, why we are doing. So then simply you say, yes, and nothing, last day you have passed the urine, so therefore we are now cleaning it. So then child start thinking, oh, I have passed the urine, therefore I have to do the work now. So that is how you are making the child aware. Okay, so in the next day morning, when you are cleaning the bed sheet and so many other things related to this messy thing which is happening, you include the child also. And don't scold him or don't abuse him. Simply include him in the work. Then one day he will only ask, so why we are doing this? Then you tell the truth. No, parents are counselled. That is very important. Encourage the child to win the cooperation. Never humiliate and punish the child. This is very important because child is not knowing. Child is not doing it intentionally. Child is also very innocent. This part has to be understood very clear by the parents. Okay. Ensure that no drinks after 7 p.m. and sleeps by. Make the child to sleep by 10 p.m. after emptying the bladder. Wake up the child by 12 p.m. by alarm method. Alarm method is one of the best method initially. Okay, so keep an alarm at 12 p.m. or 2 p.m. etc. Then compulsorily wake up the child and make him to pass the urine. Then go into sleep again. And give the rewards to the child for every dry nights. If he's not passing, give rewards. Maybe chocolate, starting from the chocolate, pen, or any other thing. And if he is not passing for 15 days continuously, then give him a big gift, some big gift or some picnic or have a outing, etc. Okay, so then the enuresis will subside by 1 month. Useful for children of 3 to 6 years. This type of pattern, what we explained now, that is quite useful in 3 to 6 years of age to decrease the stress, avoid giving punishment to the children. Now make the night time, that bedtime, very pleasant. That is important. Tell some stories, some happy ending stories, not bad ending stories, happy ending, imaginary stories you tell. So that also helpful. Bedtime should be stress free. Okay, bedtime should be stress free. Now we talk about positive reinforcement treatment. So treatment should not be acute. At once you should not be vigorous in correcting the problems. Treatment should not be acute. It should not be vigorous. Treatment before the age of 6. Before the age of 6. It may be little vigorous when it is happening in the 10th year or 12th year, etc. But in the age of the 5, 6 is a borderline area. Up to 5 years it is considered as normal. Okay, so especially male. So don't go for vigorous treatment. Slow and steady schedule has to be followed. Positive reinforcement. No punishment should be given. And you have to go for behavioral modification. We know that he is sleeping late. We know that he is getting up late, and we know that his food hygiene is not good. Okay, and he is not maintaining the schedule, and there is no time for the breakfast, and every day he is not eating in the same time. We know all these things. First, you try to correct that. Okay, and bring the child into a timetable. Okay, fixed timetable, and let him to do the work in the same time. And that's the first behavioral modification. Okay, involve in some religious activities, involve in some of the home activities, ask the mother to help in the kitchen. Okay, so that fix a schedule, and everything will be then channelized. So reward him for the dry nuts. We are told already. Child is gifted, encouraged, and he does not wait. And suppose, in spite of doing all the effort, also sometimes child may wet. Then again, don't get back the gift. Okay, although he has failed and he passed the urine at night, but he's tried. For his try, we have to reward. So don't do these mistakes. Don't tell that if you are voiding today, then I will take away the gift that I have given the last day. Given you last day. No. This type of attitude should not be there. Okay, make the bedtime pleasant. Tell some of the stories, and daily have a walk with the child. daily have a 5 or 10 minutes walk with the child and ask him about what is happening today from the morning to evening, what are all the things that you have experienced, to which you, what are all the person with whom you have met today, and all these things, what happened in the school, what teacher told, what friends told. So try to understand the mentality and the stress of the child, okay, so that he is able to share with you, and find out the likings and non-likings of the child, okay, and TV watching, mobile watching, okay, screen time, especially screen time, that has to be reduced. And to follow this, first adults have to do that, and adults are involved in the mobile and TV, and we are asking child to not see the TV. This is not good attitude, because children is also good, child is always a good observer, okay. If the parents are doing the right thing, the same the child will also follow. If the parents are not doing the same, the child will not follow it, okay. You should not expect that. So parents' education is very important. Now, in the behavioral modification, frequent voiding during the daytime and always before the bed, that is a behavior. We are changing the behavior of the child. Previously, child is not doing this. Now you are doing it. Okay, compulsorily go for voiding before bedtime, and compulsorily go for fluid restriction. Then child should be relaxed. Use the optimal postures and take time to empty the bladder completely. Okay, it's not been a hurry. He is passing the urine in a hurry. No, it's not like that. Sometimes what happens, the children are afraid of this darkness and all, so they will not completely void the urine. Okay, so they will come back in between. So again, there is a storage retention of the urine only, and again he passes it. So at school, void regularly at least 2 or 3 times per day. Now school time, actually what happens is the toilet is not clean and all those things sometimes make the child to not pass the urine in the school. Okay, so this also is one of the cause. Now drink liberal amount of the water during the daytime, but after evening hours you restrict it. Okay, give some autonomy to the child so that confidence increases. Now that's important. Don't keep on telling everything to the child. Give some autonomy. Give some responsibility to him. Small responsibility, like bringing the potatoes from the fridge while in the kitchen, or bringing the water, or giving watering the plants. Some small responsibility you give. This increases the confidence. In turns, it also helps to come out of this particular stressful situation of nocturnal enuresis. Okay, so the regular practice of praying before the bed and mealtime and every morning, that is important. Before going to the bed, you can have a prayer, okay, or sometimes you can write in a book 10 times every day. Yes, today night I will not void the urine. I am improving. Today night I will not void the urine. Improving. I am improving day by day. So like this, every day he write for 10 times. Okay. So these are all the part of the Daiva Aparsha and Satorja Chikitsa, which is explained in our science. That we will discuss later. Then, this is called as behavioral modifications, what we are doing. Then behavioral therapy, there should be some active participation of the child in the behavioral therapy. That's what I am telling. If you want to administer the behavioral therapy, there should be active participation of the child. If the child is not interested, all these steps are waste. First, prepare the child for that. Okay. So also involved with the commitments of the parents and the pediatrician. Another thing is motivational therapy. It also includes all the same thing. I will not going to repeat it. Convince the parents that child is not intentionally doing it, and it also want the dry nights and rewards and all. So child is encouraged to assume the responsibility for his enuresis and actively participate in the treatment. Move from the blame to wet night to praise for the dry nights. Okay, a dry night should be receive a positive recognition and should receive a lavish rewards, words of praise, encouraging words. A major breakthrough may warrant the material reward. Now we can go for some of the bladder strengthening exercise, as I told you, emptying the bladder before the sleep and drinking large quantity of the water during the daytime and holding the urine. So this gives the practice we have discussed earlier. Asked to hold the urine for 1 to 2 times per day unless it is very uncomfortable. This leads to a slow increase in the bladder capacity. Whenever in the daytime he got the urine urgency, ask him to hold it for a few minutes, up to 10 minutes. Okay, at the bladder capacity level of 240 ml to 360 ml, bedwetting usually stops. If the bladder capacity increases up to 240 to 360 ml, usually bedwetting stops. So you try to educate the child or to increase his bladder capacity up to this particular level. Alram method, one of the very important method, first line of the treatment. If you see the Shayya mutra treatment, the first line of method treatment is always LRAM method. Okay, so LRAM method, role of parent is very good, because LRAM, by LRAM you should not expect the child should get up. No, first parent has to get up and they will wake up the child. Okay, punctuality is very important. Every day it has to be done. So this offers the possibility of sustained improvement of enuresis and should be considered in every patient. This is the first line of treatment. And if it is not working, failed, then you have to go for the next line. Okay, this alarm is attached to the bedtime to the underwear or pajamas in a position chosen to promptly sense the wetness. Alarm method, actually what happens, this there are probe-like structures are there. That probe has to be attached to the pajamas or the underwear, and as soon as the pajamas get wet, suddenly the alarm rings and the child will get up. Okay, so when you do it for few nights, okay, so naturally as soon as the bladder filling starts, the child will get up. Okay, so therefore this is the first line of treatment. They will stop emptying the bladder by this. Most children will not awaken by the alarm in the beginning, so now parents has to try in the beginning. So this therapy should be continued for at least 2 weeks after the sustained progress. After getting the progress also, this therapy has to be continued for 2 weeks. Okay, a relapse is more common in 29 to 66% of the cases. Alarm therapy is actually one of the highly successful method. Okay, alarm is triggered when the diaper is wet, as I told earlier, and which awaken the child from the sleep and stops the micturition. By repetitive inhibition of the micturition, a conditioning process occurs ultimately. What happens is daily, baby passes few drops of urine, immediately alarm starts and the baby get up. Okay, so that means, okay, baby has passed a few drops, but next day what happens, that will decrease. So like within few days what happens, naturally a programming will be there, so that as soon as bladder filling starts and sensations are immediately, child get up. Okay, so the relapse rate is again 30% in this method. Response of alarm therapy is already good. See, alarm therapy can be done in 2 ways. One is you keep the alarm, make the baby get up at 2 p.m. or 12 p.m. and then go for compulsorily waking up baby and going to the toilet and passing the urine. This is one method. Another is you attach a probe to the diaper area or pajamas, and as soon as the alarm starts, the child stop this urination. Now, response to the treatment is always good. Okay, added pharmacological treatment will also work. Using bedwetting alarm, by this the child becomes normal by usually 2 weeks. These are all the assessment. Patient to patient it may go into change, child to child it may go into change. To be continued for at least 4 weeks even after getting the complete results. So these are some of the important parts. Reward system, you can also, because there is some repetition, I will not go for that. You can reassure the patient. Then reward system has to be followed. And there are so many medications which are explained in the context, which we will not discuss much here. Just for information, desmopressin is given, then oxybutynin is given. Okay, so because we will going to discuss about the Ayurvedic way of management. Imipramine is one of the very important drug which is given. DDVAP, preferred medication now to treat children with the enuresis nowadays. Combination therapy, alarm therapy with the DDVAP can be also given. And looking at the prognosis, the most important objective to treat the child with enuresis is to improve self-esteem spontaneous remission, which occurs in 15% of patients. And so with this we have completed the positive reinforcement method, one of the method of treatment. So in the next class we will see some of the clinical case studies related to enuresis or nocturnal enuresis or Shayya mutra, and then we will, in the meantime, we will discuss the Ayurvedic method of management of Shayya mutra by using Sattva Chikitsa. Thank you very much for patiently listening to me. Don't forget to subscribe my channel, Medical Classes by Srinidhi Kumar Acharya, and also give your comments. Thank you very much.